Hello, my name is Chris Hallemeier. I'm a radiation oncologist at Mayo Clinic in Rochester, Minnesota. It's my pleasure to speak at this anal cancer patient summit on radiotherapy for anal cancer. Specifically, I'm going to be reviewing recent clinical practice guidelines released by ASTRO. So full publication of these guidelines can be found in the journal Practical Radiation Oncology, published earlier this year. The goal of the ASTRO guidelines was to provide evidence-based recommendations for the treatment of anal squamous cell carcinoma. The guidelines were put forth by a task force with representatives from radiation oncology, medical oncology, colorectal surgery, and importantly, a patient advocate. Of note, multidisciplinary evaluation and decision-making is recommended for all anal cancer patients, given the complexity of decisions that need to be made. The clinical practice guideline addresses 4 key questions, or KQs, as they'll be referred to. For patients with localized anal cancer, what are the appropriate indications for radiation, systemic therapy, and surgery? That's KQ1. KQ2 is what are the appropriate radiation techniques? KQ3 is what are the most appropriate radiation regimens, target volumes, and dose constraints? KQ4 address the most appropriate surveillance strategies after definitive treatment. For KQ1, the guidelines recommend that most patients should be treated with concurrent chemoradiation. The standard chemotherapy drugs are 5-FU or capecitabine combined with mitomycin. Cisplatin may be used in substitution for mitomycin in particular circumstances. It's also notable that select patients with very early disease may be considered for local excision alone in avoidance of chemoradiotherapy. However, this decision should be made in a multidisciplinary manner. KQ2 addresses the optimal radiation techniques. Guidelines recommend that IMRT, or intensity modulated radiation therapy, is recommended over conventional radiation planning. IMRT allows for better targeting of the tumor while protecting healthy tissues. You can see in the side-by-side comparison where red and orange represent higher doses of radiation treatment. IMRT is able to better direct the highest doses of radiation to the anal canal and regional lymph nodes while reducing radiation to the skin, genitalia, bowel, and bladder, which should translate into less side effects from treatment. KQ3 addresses the optimal radiation regimens, target volumes, and dose constraints. The panel recommends that for early stage disease, 45 to 50.4 gray delivered over 5 to 5.5 weeks is the preferred regimen. For larger and more advanced disease, higher doses of radiation over 5.5 to 6.5 weeks are recommended. The guidelines also provide direction on the optimal radiation targets, specifically what sort of margin and what should be targeted in terms of the anal canal primary tumor, as well as the pelvic and inguinal lymph node regions. The guidelines provide recommendations on how to limit healthy tissue exposure and side effects. For example, optimal positioning techniques such as full bladder treatment and use of vaginal dilator for women, and also provides dose limits for healthy tissues in order to minimize the risk of side effects. As an example, here you can see that treating with a full bladder technique, the bladder is outlined here in yellow, helps displace small bowel out of the pelvis, which is the area that's being targeted. Conversely, if the bladder is not full, the bladder deflates and more small bowel falls down into the pelvis, which could result in greater bowel toxicity in the short and long term. So treatment with treatment with full bladder is important in minimizing side effects from treatment. Also, for female patients, vaginal dilator should be considered. This helps reduce radiation exposure to the anterior wall of the vagina. You can see here treatment without a dilator versus with the dilator. The dilator helps push the anterior wall of the vagina away from the anal canal tumor and can reduce short and long-term sexual toxicity from treatment. Also important to note that once a course of radiation treatment begins, treatment breaks should be avoided, as evidence shows that delays can reduce treatment effectiveness. Going hand in hand with this, aggressive management of side effects during treatment is critical. So management of skin reaction, bowel, bladder side effects is critical in ensuring that the treatment can be completed without the need for breaks and have the best chance for cure. KQ4 addresses surveillance strategies after definitive chemoradiation. It's recommended that patients are followed closely in the first few years after treatment, so specifically every 3 months for the first year. Assuming the tumor has responded, then the surveillance interval can be spread out to every 6 to 12 months up through year 5. Physical exam is the primary modality for assessing treatment response, so digital rectal exam is critical. Anoscopy can be added, and imaging is considered on a case-by-case basis depending on the stage of the tumor at initial diagnosis, and this could include a CT scan, MRI scan, or PET scans. Close monitoring is critical in order to avoid unnecessary surgery for tumors that are responding to treatment. We know that anal cancer can take 6 months and sometimes even longer to completely resolve after treatment. So we want to monitor the tumor closely to make sure it's responding and would reserve surgery for tumors that aren't responding or have not completely resolved after at least 6 months from completion of treatment. Close monitoring is also important in detecting early recurrence. We know that salvage surgery with an APR can cure patients that do not have a complete response or have recurrence after chemoradiation. So it's important to catch a potential recurrence as early as possible. The guidelines also highlight ongoing research studies that are looking at improving outcomes for patients with anal cancer. For early stage disease, clinical trials are looking at using lower radiation doses or less intensive chemotherapy to preserve high rates of cure, but reduce short and long-term side effects from treatment. For more advanced disease, there are trials looking at higher radiation doses and or adding immunotherapy to try to increase responses, increase cure rate. However, it'll be important to assess the increased side effects associated with these changes in the standard treatment to determine if the benefits outweigh the risks. There's also interest in exploring adaptive radiation. This allows the radiation oncology team to adjust the radiation plan potentially as often as every day in case there are changes in patient anatomy, the tumor, or the body during the course of the 5 to 6 week course of treatment. There's a lot of interest in looking at blood-based biomarkers, specifically circulating tumor DNA, which could be used to help predict outcomes, guide treatment, and monitor recurrence. There's also recognition of the need for greater research focus on survivorship and rehabilitation, especially addressing bowel and bladder toxicity that we know is very common with this treatment. I'd like to thank ASTRO for leading the development of these guidelines. It's a privilege to take part in this exercise, and I think that overall these guidelines will improve the quality of care for anal cancer patients and survivors around the world. If you'd like to dig deeper into this, there's a podcast on practical radiation oncology that talks a little bit more about the guidelines. This should be available for anyone to access, so please check that out. I'd like to thank you for your time and attention, and feel free to reach out to me with any questions.